Okay, good afternoon everybody, and we go through the safety announcement. Please bear with me because we have to read this out. I'd like to welcome you all here today to Lincolnshire's Health and Wellbeing Board meeting, and that includes everybody within the council chamber, and indeed it's lovely to see some visitors here as well, so welcome members of the public. Pleased to see you. Before we begin, and for those of us in the council chamber, there's no fire drill planned for this afternoon. In the event of a fire alarm sounding, we need to leave the council chamber through the rear doors. This is where I do my air stewardess impression. Rear doors at the back, although there's some around the sides here. And then through reception and assemble in the car park at the front of the building. Can I please remind everybody to ensure that their mobiles and devices are all on silent? Also, when invited to speak, can you please ensure that you switch on your microphone? Otherwise, the officers attending the meeting via Teams and members of the press and public listening to our meeting online won't be able to hear you. If you wish to ask a question during the course of the meeting, can you please raise your hand and my Vice Chairman, John Turner, will make a note of those who wish to speak. Thank you. So if you move on to apologies for absence and replacement members, Katrina.
Thank you, Chairman. We've received apologies from Councillor Cook.
Katrina, can you just pull the microphone?
Oh, sorry, Chairman. Yes, we've received apologies from Councillor Cook, Glenn Garrod, Jerry McSorley, Sunhill Hendosha, Elaine Bayliss, Andrew Morgan, Maz Foss, Councillor Richard Wright, and we've actually got Councillor Stephen Clegg here as his replacement member today. Thank you, Chairman.
Thank you, Katrina. Okay, can we move on to, are there any other apologies? Sorry, before I move on. And I understand Councillor Clegg, is it you're substituting for Councillor Wright?
Yes, Chairman, I am. Thank you.
Members of declaration of members' interests. Are there any interests? So we move on to the minutes of the last meeting, which was held on the 28th of September. So this is quite some time ago. Can we, first of all, just for those who were here, can we just go through for accuracy page, and I'll do it according to the agenda, page 5, page 6, page 7, page 8, page 9, page 10, page 11, and page 12. Okay, I think that's okay. And then matters arising which are, sorry, trying to get, can we have a seconder for those papers? Thank you, Councillor Kendrick. So the, everybody in favour? Yes. Any, I will just ask any against or abstentions. No. So, obviously, thank you.
Abstention.
Thank you. Okay, we move on to agenda item 4, which were the actions. Rather than laboriously go through each one, Alison, is there anything that we need to update on?
No, there's no matters arising from the action list. They're as noted on the page.
Thank you. Has anybody got any points or questions that they want to ask on agenda item 4? No? Thank you. So we then move on to item 5, which are the chairman's announcements. First of all, it's my pleasure to introduce, are you ready for this, Andrew? Sir Andrew Cash, who is the interim chair of the Lincolnshire Integrated Care Board. Delighted that you could be here today, Andrew, and very much look forward to working with you in the future. I think that anybody who needs to know more about Andrew's background, please Google him online and you'll find all of the information. But I think it's fair to say that we are very lucky in Lincolnshire to have this opportunity to invite Andrew in to help in our county and our wider health system. We've got a lot of experience sitting on those shoulders, so it's really good to see you here. The second point around the executive appointments, the interviews have taken place, but the appointments are yet to be announced. I don't know, John, if you actually know when that's likely to be.
You mean the non-executive?
Yeah. No, yes. Sorry, I'm doing a very good impression of Vicar of Dibley, aren't I? Oops.
But to answer your question,
Yes.
Chair,
Yes, thank you.
we are anticipating that the next week or two we hope to be able to make a public statement in terms of the non-executive director appointments to the Lincolnshire Integrated Care Board. Thank you.
Thank you. And yes, as you so just tripped up there, the executive appointments are obviously to the board itself, and that's more on the clinical side of things. Okay, so other than that, unless anybody again wants to ask me anything, or indeed colleagues anything on the chairman's announcements. Yes, Councillor Clegg.
Thank you, Chairman. I may. I've got two items, if you like, on page 15-16, the public health arrangements for Greater Lincolnshire and the joint strategic needs assessment update on pages 16 and 17. Would you like me to ask one and wait for a response, or ask both? Which would you prefer? Well, I'll do two at a time, if I may, if that's all right with you. Excuse me. Right, thank you. Feedback from the District Council network is as follows. Reference the public health arrangements for Greater Lincolnshire. We would like to understand the full rationale for this and how it will work in practice. There are differences, as I'm sure we know, in the community makeup, with North East Lincolnshire being more urban rather than rural, as is the case in Lincolnshire itself, for the most part. We'd also like to check that there are no concerns that this will dilute the service and support that we have in Lincolnshire already. That's my first question. Would you like me to carry on?
Hang on a moment. Let's get the Director of Public Health to answer that first one. Thank you.
Thank you. Thanks for the question. We have addressed some of these within scrutiny as well, but just to reiterate for the Health and Wellbeing Board, when you look at Greater Lincolnshire, it depends on the focus, the focal length that you look at. If we go down below upper tier authorities, it's a very dispersed community, very mixed community, and actually the Director of Public Health report for this year coming will describe that, and what we're actually looking at is there are some similarities between districts and parts of North and North East Lincolnshire that maybe weren't as apparent as they would have been had we not been looking at Greater Lincolnshire as a whole. But having said that, very happy to have a conversation with District Council colleagues about the arrangements. We have some papers that are in the public domain. Happy to share those with Chief Execs leaders, however you prefer, so you can see the background. I'm very happy to follow that up with a conversation in whatever format works, just to provide some assurance. What I would say on this, though, is the whole point of a Greater Lincolnshire public health approach is we won't dilute, we'll become stronger. An example of that is in Lincolnshire at the moment, I'm really lucky, I've got 2 consultants and an assistant director. In North East Lincolnshire there's 1, and we're going out to recruit in North East Lincolnshire, so we'll have, North Lincolnshire we'll have 2, and in North East we've got 3 consultants. So we've actually gone from 2 consultants in Lincolnshire now to 6 consultants across Greater Lincolnshire. So it's in those sort of ways we're looking at increasing our resilience as we recover from COVID.
Thank you, Derek. And your second question?
Thank you, Chairman, and thank you to Mr. Ward for his response. That's reassuring. Reference pages 16 and 17, the Joint Strategic Needs Assessment update. It would be very helpful to see the timetable and topic leads for the 3 chapter headings for this, and we would welcome a discussion with the Public Health Officer facilitating this work to understand it in more detail, to make sure that the districts are fully engaged in this process to share and feed local intelligence and knowledge in a meaningful and comprehensive way, rather than simply providing raw data, not necessarily in context. Thank you.
Thank you. Can I reassure you personally, I'm going to ask Derek again if he'll make a comment, but absolutely should the districts be part of this and an integral part of our assessment and our refresh. It goes without saying that it's not going to work if we don't have district input at the very highest level. Anything you'd like to add, Derek?
Yeah, just to break it down into a few different bits. Really welcome the opportunity to speak to our districts. We are already actually in conversations with districts because I think partly because of the COVID response, we've worked so closely with our district council colleagues and politicians, the leaders through the Lincolnshire Outbreak Engagement Board, that there's a reinvigorated, I think, approach to try to make sure that we get health and wellbeing on everybody's agenda, and on that I did speak to colleagues from East Lindsey, Boston, South Holland on what they want to do, and we're working on that. I think in terms of the JSNA specifically, there's 2 parts to it roughly. One is the data, and that is national data sources that we are bringing together in a new system so that people will be able to interrogate it and cut it in lots of different ways. So whether it's a district council view or a ward view, or whether it's a primary care network view, or whether it's a Lincolnshire ICS view, or indeed some of the Greater Lincolnshire stuff, people will be able to look at it in any different way. The third part of this is that then there will be a narrative that goes along with it around those 3 different areas, and that's the area it would be really good to catch up with district colleagues and with our NHS colleagues to make sure that we get that, and we're already talking about that with our PCNs.
Okay.
Thank you, Chairman, and thank you again, Mr. Ward.
Derek, doing a bit of a Peter Levy here and putting you on the spot, I do just wonder if you would be kind enough to update us as far as COVID is concerned.
Thank you, Chair. Yeah, I'll summarise, but I've got all the numbers. The overall position is from the end of last month, where we were between 200 and 300 per 100,000 population, we've sort of tripled and in North Links quadrupled our rates. So there is a huge amount of COVID-19 going around in the general population. I'm sure everybody's aware of that from general media and from websites and newspapers. We can see that there is a very large amount of COVID. The 3 reasons for that are there is indication that the booster that a lot of people got before Christmas and over the winter is starting to wane, and we have the spring booster campaign that's going to help to deal with that. Secondly, we've got a new variant of Omicron, so it's still Omicron, but it's called BA2, and whilst Omicron, BA1, was very, very good and very effective in terms of infecting people, highly infectious version of COVID. BA2 is even more so, perhaps even up to 40% more infectious. So that's the second reason we're seeing so much COVID in the community. And the third reason is obviously the living with COVID strategy and the government approach has meant an easing of the non-pharmaceutical interventions, and people's behaviours are changing, and that's driving the case rates as well. Over the past 3 or 4 days, we've seen the numbers across Lincolnshire sort of start to level out. They're around 950 per 100,000, so they've gone up very significantly over a month, but they are starting to level out. I'm not going to bet the mortgage on whether they'll go up, down, or stay the same, but we do tend to see with Easter, with holidays, that does tend to bring rates down. So fingers crossed we will start to see those rates come down. The good news about BA2 and Omicron generally is we have seen an increase in the number of people who are in a hospital bed with Omicron, but the majority of those people have got it in addition to the reason that they're in the bed for. I think as of yesterday, we only had one person in an ICU bed with COVID, and I think there was 1 or 2 on mechanical ventilation. So the vast majority of people in hospital aren't needing any support for the fact that they've got the disease, and that's down to the fact that the vaccine is very effective in reducing the severity of the disease. So whilst Omicron's proven very difficult to stop people catching it, the vaccine is stopping you getting severe disease. So the 3 messages I would push out through here, and I've been pushing out through lots of different mechanisms, are: 1, get your vaccine. Even if it doesn't stop you catching the disease, it will protect you from getting severe disease. Secondly, whilst we can, and we've got a few more days yet, test and book yourself, get yourself some free lateral flow test kits in and test yourself. And thirdly, let's remember the basics, which everybody's sick of, I'm sure, hearing me say, but hands, face, space, fresh air will protect against all versions of COVID and lots of other nasty bugs and viruses at this time of year. So in a nutshell, that's where we are. Happy to go into more detail if you'd like.
Thank you for that. Are there any questions for Derek at all? Okay, thank you. Moving on to the item 6A, which is the Lincolnshire Pharmaceutical Needs Assessment. And I understand that Lucy and Andre will be presenting. So I will now pass over to Lucy.
Thank you, Councillor Woolley. Good afternoon, everybody. Hopefully you can hear me and see both Anjo and myself now on the screen. So just before I begin, I'll introduce myself. I'm Lucy Gavins. I'm one of the consultants in public health at Lincolnshire County Council within Derek's public health team. And Anjo is an associate lecturer at the School of Pharmacy at the University of Lincoln. And Anjo and I have been working really closely with Alison as well to develop the pharmaceutical needs assessment. So the pharmaceutical needs assessment, or the PNA for short, is an assessment of our current and expected future pharmaceutical needs, or need for pharmaceutical services in Lincolnshire. The services that we're talking about are provided by a range of different organisations, for example, community pharmacies that you might see on the high street, dispensing general practices and others. And so the document, the PNA, is used as a framework for commissioning those pharmacy services within Lincolnshire. And it's a statutory requirement of the Health and Wellbeing Board. Up to now, the PNA must be refreshed or updated every 3 years. And so this PNA that we're talking about today is due to be published on the 1st of October this year. And then moving forwards, there are some new pharmaceutical regulations that were updated just at the end of last year that state the Health and Wellbeing Board must review the PNA at least every 5 years. So this is kind of an ongoing cycle. To understand the need across Lincolnshire, the steering group has collated and analysed data from a number of different sources, including NHS England and improvement data on community pharmacies, a pharmacy and dispensing contractor questionnaire, and some public engagement that was led by Healthwatch. So we've pulled together information from those sources, and you'll see that in the PNA as it's been presented to you today. And our analysis concluded that there is adequate access to pharmaceutical services across Lincolnshire, with, as we'd expect, a greater number of community pharmacies in districts with larger populations, and access to pharmacy services through those dispensing GP surgeries for many residents in the more rural parts of our county. Most people living in Lincolnshire can access a pharmacy within 30 minutes by car or public transport, including at the weekends. That's one of the key things that we looked at. But obviously it will be important to monitor changes in the size and the age of the population over the coming years, and also taking into account key factors like our ageing population, the number of carers and people requiring care, and the needs of people living in specific settings, for example, caravan parks. And so we've taken all that into account within this P&A, and we will continue to look at that as we move forwards, to make sure that we're continuing to understand the needs of the population. The P&A itself within section 7 concludes with a number of statements around need in Lincolnshire, which board members are asked to note as part of the paper today. And we're also seeking approval of this draft P&A in preparation for going out to formal consultation. And I'll just take a couple of minutes to talk about what that consultation will involve. The plan is to run the consultation from the 19th of April, so that's the Tuesday after the Easter weekend, until Monday the 19th of June, which is a total of 63 days. We'll consult through the LCC online platform, Let's Talk Lincolnshire, but provision is also in place for people to request paper copies of the P&A and also the consultation questionnaire. And we've also worked with colleagues at Healthwatch Lincolnshire, who are kind of willing and able to provide support to anyone who might need it, either in reading the draft P&A, which obviously is quite a long document, and also for completing the questionnaire. And additionally, during that consultation period, we'll be running a workshop with members of the Health Scrutiny Committee to review the draft P&A and feedback. And any feedback that's shared will be considered when we edit the final document. So the plans for the consultation follow guidance from the Department of Health and Social Care on who should be consulted and what questions we should ask. All we've done is made some very minor tweaks to the language in the questions because we felt there was quite a lot of technical jargon in there and we wanted to make the questions as accessible as possible. But otherwise, we're quite closely following that national guidance around what the consultation, who it should speak to and what it should ask. And then just finally, the P&A steering group and Lincolnshire County Council's corporate engagement team have also completed an equity impact analysis of the P&A for those with protected characteristics, and as part of the pre-engagement work for the draft, for pulling together this draft. And obviously that assessment will be updated to reflect any additional feedback that we get during the consultation period. And then just in terms of next steps, the results of the consultation will be considered by the steering group when we meet in early July, and then a finalised P&A will be produced for the Health and Wellbeing Board to approve for publication when you get together on the 27th of September. So that's a kind of a brief summary of everything that's in the key findings of the P&A, the next steps for us and what we're seeking from the Health and Wellbeing Board today. And I'll pause there in case there are any questions.
Thank you, Lucy. Right, questions, anyone? Councillor Bradwell.
Thank you, Chairman. It doesn't seem that long since we were talking about this. It's 5 years ago. God. I do worry a bit about, I mean, I've just been looking actually about how many GP services prescribe, but for me it's about being able to get a service on a Sunday. In fact, in Woodall, well, our chemist is dire. You queue for hours, and we're not even in COVID now, but it's Boots. I mean, it's just horrendous. But I do worry because a lot of people, you know, you would say everybody has a car, but people don't have a car or don't have the ability to get somewhere. And I think on a Sunday, at least the chemist should be open at least for a couple of hours because people are poorly. I mean, a lot of people where I go would go to Louth Hospital, to the urgent care centre and get drugs. But, you know, you could have gone and got something from the chemist. So I do think you're all right if you're in a town, but you're not all right if you're in a village, a large village or whatever, because chemists don't open. And you might say, oh, people should get their drugs and think about it and have them in the cupboard. You probably should do, but people don't. And I just wonder whether that should be, is that something we could put in this review, or is that something that chemists have to, they decide themselves when they open? That's what I'm really asking.
Thank you, Councillor Bradwell. Lucy, would you like to comment on the rurality aspect and the sparsity side of things?
Yeah, absolutely. So we've looked quite closely at the data around where the pharmacies are, and obviously this is it's a real challenge and something we were conscious of, especially when we start to look at things like travel times. Absolutely, that people might not have access to a car. There is a challenge around the opening hours, because pharmacies can largely choose their own opening hours. Some of them might be open for kind of much longer periods of time, but they can still choose which hours they open. So it does make it difficult, and on a Sunday it does mean that there is slightly less availability. Absolutely, some people will be proactive and go out and get something in advance, or have some something in the cupboard, but lots of people may find themselves suddenly ill on a Sunday and not quite have the medication that they need to hand. So it is something that we are very conscious of, and are working kind of to understand what we might be able to do and suggest locally to improve that offer.
Thank you, Lucy. Derek.
Just to pick up on what Lucy's just said, completely understand what Councillor Bradwell's concerns are. I think just with the PNA specifically, it's a factual document. It's about, this is what we've got at the moment. I think it, along with, and we just mentioned it, the Joint Strategic Needs Assessment, the Joint Health and Wellbeing Strategy, they can all feed into future commissioning decisions. But at the moment, the paper in front of the board is about the process, which is quite tightly constrained by central government actually in the legislation for the PNA that we need to go through. I think at the moment this is with NHS England, but it will be moving over into the ICB subject to the legislation coming through. So that would be probably a good time, an appetite time to talk about pharmacy provision. Once we've gone through the process that we need to go through for the PNA, once the white paper's gone through and the ICB is in place, I think looking at the breadth and depth of the intelligence we've got and having a conversation about pharmacy provision in Lincolnshire, that would seem to me to be a good time to do that.
Thank you, Derek. John.
Thank you, Chair. First thing I wanted to say is to Lucy and to Andre. There's obviously a huge amount of work that's gone in to developing this needs assessment. I actually found it a really interesting document to read, and there's some great material in about deprivation and needs across our whole community that I think applies not just to pharmaceutical needs assessment, but the broader health and wellbeing status of our population. So firstly, just wanted to recognise the depth of the work that's been put in to date. And I think, like Councillor Bradwell, I'll be really interested to hear how the public engagement exercise goes, or is it public consultation, and the feedback we get from our communities across the county. I think the question I really have just for now is I'm not sure what it is and isn't telling me. And by that I mean it's very rare in my world at the moment that we do an assessment of need or have a conversation about services, and the findings are that there don't appear to be much additional demand or requirement for additional services here. Because clearly we ask a lot of our pharmacies. Pharmacy is even more, the front line of our health service, even more than general practice in terms of footfall and the use by the communities we serve. We know about the dynamics of the geography and our population in Lincolnshire. getting younger, if only, getting older, the demands of an ageing population, public expectations, all of these sorts of things. We know that we've got some quite significant housing growth, in play across many of the patches in the county. So I'm just a bit thoughtful about knowing all of that and everything else, if I'm understanding what the report is saying, which I'm reading at first glance, so to speak, as being there isn't a fundamental need for any material changes in provision. I'm not sure if it is saying that, but I just wanted to ask if that is what it's saying, and if not, what it is saying. So I'll pause there. Thank you, Sue.
Thank you, John. Derek, would you like to come back on that?
If I start, and then I'll let Lucy and Anjay come in, because they'll have the detail. I think it comes back to that point about this is quite a tightly prescribed document in the national legislation. And when we have gone through the process and analysed the data, given those parameters, then generally speaking, we are saying that we have enough provision for Lincolnshire based on that criteria. Notwithstanding, we may want quicker access, longer hours in Lincolnshire for Lincolnshire. So I think there's two different things there. And I think Lucy did mention it, and I'll pass over to her in a second. In section 7 of the document, that in as simple language, but within the framework of PNAs nationally, is what we are saying as the team that have pulled it together, and we were asking the Health and Wellbeing Board to endorse that to go out to consultation based on the national approach, which is, we're satisfied that we've got evidence about the number and the geographical distribution, etc., etc. So it's worth board members having a look through that section 7, the statements of the PNA. They are all factually correct based on our analysis and the national policy. Notwithstanding, we may want a different model separate to the process of the PNA. So sorry to be a bit bureaucratic, but that is a process. I don't know whether Alison's also been fundamental to driving this on, so she might want to mention some of the national policy, and Lucy and Anjay might want to jump in as well.
Yeah, thanks, Derek. Alison, did you want to come in next? Thanks, Derek. Yeah, I would absolutely agree. I think the key within the PNA is that we're reporting on, I suppose, what are classed as essential services. So things like places where you can dispense a prescription, repeat prescriptions, get rid of unwanted medicines, that kind of thing. But there's absolutely a bigger picture for us here. This is almost a baseline of our core pharmacy service, but there's much more that we can do by working closely with pharmacy services around a whole host of areas around things like smoking cessation and hypertension case finding and things like that. And that work is sort of ongoing in parallel, I would say, to the PNA, which, as Derek said, is very tightly prescribed by national government.
Alison?
I was going to say something very similar, and it is very much about following the process, because the only sort of objections we can have against the PNA is if we haven't followed the process properly. So doing the 60-day consultation in terms of a judicial review, it's have we followed the process, and we have very much followed the process and the framework that's set down by the legislation. So, yeah.
Yes, John. Yes.
Thanks, Derek and Lucy. Alison, okay, I think I understand all of that. One of the reasons why this is so important for me, as well as all of us, is because clearly the Integrated Care Board, once we get established, and from the 1st of April next year, we will have responsibility for pharmacy, optometry and dental primary care provision in the same way we do for the general medical practitioners. So I'm just trying to think what it is that we'll be inheriting and having to take on board in terms of the pharmacy side of the house now. In different areas, we know we've got huge challenges around general dental practitioner services across the county. I don't get a sense that we're in anything like that sort of position with pharmacy services, but clearly we're going to have a public consultation exercise. Now, presumably the public we serve might want to raise a whole raft of issues about comprehensiveness of service provision, and similar to the way that Councillor Bradwell raised as well. So obviously, we need to see what comes through with that. But in terms of the needs assessment, would the public consultation exercise change the needs assessment, or are you fundamentally saying, no, this is the needs assessment because, as Derek said, these are the facts of the matter at the moment, and so it's almost what is the purpose of the public consultation exercise in terms of the sort of material that will come out of it? Do we then flow into a strategy? Does it connect into a plan? How do we take it forward from there? Sorry, that sounds like a bit of a ramble, but hopefully you get a point I'm driving at.
Derek.
I'll try to break it down to 3 blocks, and then we can pick up from that. So question 1, do we meet the mandatory requirements of the PNA? And if that was no, we would need to say that here, and we would need to do something about it straight away. Based on the facts of what we've got, the statements of the PNA are that there is no obvious gap given the government blueprint about this is what you must have. So we're not in category 1, we've got some clear fundamental gaps that the PNA is saying we've got. We go out to consultation, there might be a challenge that we haven't gone through due process, we're comfortable we have gone through the correct process, but we will get a whole range of different views in on pharmacy provision that aren't simply, have you done what the PNA says you must do? We might get some people who say you have or you haven't, but the majority will be, actually I think we should have this. Then point 3 or part 3 is, great, okay, so we've ticked the PNA box. We know we've got, as I think Lucy said, a baseline for our pharmacy services across Lincolnshire. What do we actually want it to look like? How do we want our primary and community care services in a broader sense, not just pharmacy, to look? And how does the work that we've done in the PNA, the work that we've got in the Joint Strategic Needs Assessment, and lots of other sources help us decide that? And then how do we go from where we are to where we need to be? I think the bottom line is we have baseline provision of pharmacy across Lincolnshire, which is a good news story, subject to the consultation. The question is, within the finite resources we've all got to deal with, what's the general view about how we balance that up with, if we've got X amount to spend, do we spend it on more pharmacies? Do we want more dentists? Do we want more GP? All of the issues that clearly as the Chief Exec designate are top of your list.
Thank you. Councillor Kendrick.
Thank you, Chairman. It's just a quick question on the process of the consultation. Can I assume that key interest groups will be consulted, such as groups which deal with older adults and so on? Is there specifically named groups that you go to as well as the general public? Thank you.
Lucy?
Yes, absolutely. We consult with a wide range of groups. Many of whom we've got we're used to working with locally, and also making sure that we cover off groups that nationally we are advised that we should consult with. So there's quite a long list of groups that we would consult with. Yeah.
Thank you. And Councillor Clegg.
Thank you, Chairman. I came with a long list of questions, but you'll be pleased to know that they've mostly been answered. But I just wanted to follow on from Councillor Kendrick's question about consultation, and indeed some of the points that Mr. Turner made. Just for clarification, I'm pleased, and Lucy, what you were saying about you've got these groups that you you're consulting, and obviously we would be happy to help facilitate this in terms of individuals or indeed local groups that our respective district councils are in regular communication with, and indeed we would help promote this consultation as well. There was one point in the report reference to online pharmacies. And obviously, we were discussing about access to public to transport to get to pharmacies. We were talking about opening hours and so on. And I don't know the information here, the answer to this clearly, because I wouldn't be asking the question. But one assumes with the what's been going on over the last couple of years, people's usage of online services such as online pharmacies will have increased. I don't know, but I'd be interested to know about that, and specifically to this the P&A, the consultation process. Will online pharmacies or pharmacy companies be consulted? Thank you.
Lucy?
Thank you, Councillor Woolley. That's a really good question. And Anjay, can I come to you on that one, actually, around the online pharmacy specifically?
Yes, thank you. Yes, online pharmacies, we have 5 as of February 2022. We have 5 online pharmacies across Lincolnshire, and they all have been sent. They all have been consulted during the pre-engagement stage in July, and obviously, naturally, they will be also part of the kind of public consultation as well. So, and they are included in our analysis as well. And to answer your question, yeah, that is a growing population within the kind of pharmaceutical list of pharmacies, because decision as to whether a online pharmacy can open or not does not depend on the P&A. That's just like a legal thing that that kind of comes into the P&A process.
Thank you. Alison?
Yes, Andy's sort of answered my question. Anyone who's on the pharmaceutical list for the Lincolnshire Health and Wellbeing Board area, which includes online pharmacies and community pharmacies, will be consulted as part of the process.
Thank you. Councillor Gray?
Madam Chair, thanks very much. I think we were told during the presentation that Health Watch Lincolnshire would help complete the form. I mean, I've looked at the form, of course, because I've read the papers. I think there's 7 or 8 pages of questionnaire, and it's reasonably involved and quite complicated, especially for an older person, I have to say. As elected members, could we have contacts of those Health Watch contacts so that we know who they are? Sometimes it's difficult to find out who the Health Watch contacts are in our area. So I think as elected members at county level and at district level, that would be very useful.
Thank you. Sarah, would you like to answer that?
Yes, sure. So I'm Sarah Fletcher, I'm from Health Watch, Lincolnshire, so good afternoon. Yes, we can certainly make sure that our contact details are shared. We are a fairly small team. We hope to get some volunteers as well trained up so that they can support to extend our reach and opportunity. Obviously, you know, we are still going through, as we've heard earlier, some COVID problems. So a lot of this we would hope would be by telephone and online. But where somebody felt that face-to-face support would help, then obviously we'll do what we can, because I agree it is quite a lengthy questionnaire, and there might be some discussions required as well. So we'll make sure all our details are shared through the Health and Wellbeing Board.
Thank you, Sarah. Are there any more questions from anyone? Councillor Bouquet.
Yeah, just quickly. 2.2.2, prevalence of disease and chronic conditions. Not highly surprising, but First Coastal PCN is all red. Oh no, we've got 1 yellow. Sorry, 1 yellow. Just to mention that obviously we are failing on the East Coast, and obviously that's where we get most of our deprivation, and John knows my issues there, but it just stands out there really, really badly. So, yeah, lots of work to do on the East Coast still.
Okay, thank you for that. Are there any other questions? In that case, can I go to the actions required? I'm not going to read these all out. Are you happy to take them en bloc? Is everybody content to agree the actions? Anybody unhappy or any abstentions? No, don't see any, so thank you. We will take those as agreed. Can we now move on to item 7A, which is an update from John Turner on the integrated care system. John.
Thank you, Sue. There's a paper and some supporting papers in your pack. I must say the world of the development of integrated care systems and the core component parts is a rapidly evolving and developing one. So I thought rather than churn through the papers, although I'm very happy to take any questions in relation to what we've got in the papers, I'll perhaps just give you all a sort of latest position update on where we are with the core components of our developing integrated care system here in Lincolnshire, Better Lives Lincolnshire. So just to remind everybody that the white paper was presented to Parliament last year, and legislation is currently going through Parliament. Just last week it came back from the Lords to the Commons, and there's nothing that I'm aware of or been briefed on that is causing a concern that the legislation may not be able to be passed in time to enable all of the new statutory arrangements to become established on the 1st of July, but obviously it's still subject to parliamentary process. And to remind the board that currently Lincolnshire, like the other 41 geographies across England, already do have integrated care system sort of designation in a sort of less formal manner than is anticipated once the legislation is passed, and we will become a statutory integrated care system. There are quite a few component parts to the new integrated care system, but just to remind the Health and Wellbeing Board actually what the point of all of this is, and there are four core purposes of an integrated care system. The first is about improving health outcomes for the population we serve. Second is about reducing health inequalities in the population we serve. Third is providing productivity and sort of efficiency and value for money for the taxpayer. And finally is for the NHS to increase its social and economic contribution and value to the population it serves. So that's kind of what we're trying to do with our integrated care systems. I sort of describe it in a slightly different way, which hopefully sits alongside this nicely, in two frames. Firstly, when it comes to the actual hands-on delivery of care for people, we want that care to be integrated and joined up and cohesive in a way that we know it isn't at the moment, so that all of the handoffs and frustrations that we know exist within the hands-on delivery care, GP to hospital, to mental health service, to social care, that we really pay attention to ensuring we integrate around the needs of patients and their families. The second sort of integrated care approach is actually that we care for the health and well-being of our communities together in an integrated way, and that's in the very broadest sense, social determinants, and all the contributions around housing, education, health, police, third sector, everything that we all work on together. So the point of the integrated care system, I think, is less about having a system and more about us being able to provide integrated care, both in terms of the direct care people receive and an integrated approach to health and wellbeing across our communities. Okay then, John, so where are we with this? There are two core components of the new statutory integrated care system for us here in Lincolnshire and across the country as well. The first of those is the development of an integrated care partnership, which technically will be a statutory committee of the integrated care system. And we've got a paper following this on the integrated care partnership, and we're developing our approach in Lincolnshire to that. And the second is the development and establishment of an NHS Lincolnshire Integrated Care Board, which, all being well, become fully established on the 1st of July. So I just want to talk briefly about where we are with the board and the Integrated Care Partnership, then make a few comments about other new components that will be part of our integrated care system. So in terms of the board itself, obviously Andrew has been appointed as chair. We're in the process of appointing the non-executive directors. I've been appointed as designate chief executive, and we've appointed our nurse and finance directors, and we're currently in the process of recruiting a medical director, and thereafter we will be appointing the 3 partner members for the Integrated Care Board, one of whom will be from local government, one from primary care, and the third from NHS trusts. So all of that process is underway. We're also doing a huge amount of work in terms of developing our operating model, our constitution, our readiness to operate statement. So there's a vast amount of bureaucracy, necessary bureaucracy, is in the right term, sitting behind all of that. And at the moment, we're on track to get all of that in place for the 1st of July. So that's the Integrated Care Board. The Integrated Care Partnership, as I say, we'll be talking about in a few moments' time. And we've got a workshop on the 26th of July, where hopefully we will come out of that with absolute clarity about how we're going to have establish and run the Integrated Care Partnership in Lincolnshire. The Integrated Care Partnership will be as I say, a statutory committee of the Integrated Care System, but it will sit alongside the Health and Wellbeing Board, us, which will remain as obviously a statutory committee of the County Council. Part of the work we'll be doing on the 26th of April is to make sure that we're able to differentiate the roles of those two, whilst ensuring that they dovetail in together as well. Alongside that, we are developing a provider collaborative in Lincolnshire. So this is about our colleagues involved in the direct provision of services to our communities, working in a more integrated fashion. So this involves not just our 3 NHS trusts, but our primary care networks, county council colleagues, particularly adult social care, our colleagues in the third sector, and in the care home and domiciliary care sector as well. And I'm quite pleased with the progress we're making with the provider collaborative. Long way to go with it, but I think we're getting that moving nicely now. And the provider collaborative will have formally delegated to it from the Integrated Care Board responsibilities for service transformation, people and digital. Alongside that, we are creating a really, I think, exciting sort of joint alliance with County Council and other colleagues around mental health, learning disability and autism. And Sarah is Chief Executive of Lincolnshire Partnership Foundation Trust, is leading that work for us, working really closely with Glenn and I know a wide range of partners in that. Equally alongside that, we're developing a system clinical directorate. So that is bringing together all of our senior clinical, it isn't medical, it's clinical in the round, leads and experts together in one place to advise us collectively about all matters of clinical and professional best practice and integrated clinical care. So that doesn't just involve people like our nursing, medical and allied health professional clinical leads, but I know Derek, you're involved in that, our GPs are involved in that, and social care colleagues are also involved in that. So again, that's really encouraging. This is integrated care, working. Also, we're working very closely with our third sector colleagues, the Lincolnshire Voluntary Engagement Team, in terms of their providing a system lead role on the personalisation work across the county as well. And again, early days with taking that forward. Other things just to quickly note that alongside the establishment of the Integrated Care Board, we are continuing to run the NHS Lincolnshire CCG right up to its last day of the 30th of June. Clearly the CCG has very significant and important statutory responsibilities, and just to ensure everybody that we remain absolutely on that, but we're also attending to a safe and effective close down and transfer of CCG responsibilities into the Integrated Care Board. And as you can imagine, that includes TUPEing staff over and paying attention to all of our financial and audit issues. We do have a challenge financially. I don't mean with the financial position, I mean with the fact that within one financial year, we'll actually be having two statutory organisations. So you can imagine our finance colleagues have got a bit of work to do around that. Other key points is we're equally very, very clear that whilst the CCG's current responsibilities and our staff will be incorporated into the Integrated Care Board, that the Integrated Care Board is a new organisation with new ambitions, a new role and a new way of working in Lincolnshire. And we're really determined to make sure that we design our Integrated Care Board in Lincolnshire in a way that reflects that and pays attention to the ambitions and aspirations of all of our partners of that board as well. And we are working also hard, and this is currently, I think, more in the NHS side of the house, although I anticipate that we'll be looking at it in the broader partnership around how we work with our neighbouring integrated care systems, particularly those on the East Midlands footprint that we share. There are many NHS services which are best organised on a much bigger footprint than just Lincolnshire alone. And we've got some really good work being scoped out there. And as I mentioned earlier, in April next year, the Lincolnshire ICB will be taking responsibility for pharmacists, optometry and dental services, but also specialised commissioning services, health and justice service and screening services as well. So there's a lot that is coming our way. And I think importantly, just put all of that in the context of significant operational pressures day in, day out, the need to fully restore not just NHS services, but all of our public services together across the county. And I think the broader sort of levelling up agenda, which we know plays to rural, remote and coastal communities, to some of the inequalities and deprivation that some of our communities suffer, and plays to issues such as broadband and transport challenges as well as the obvious, leading economic development brief there. So there's a lot in there, Chair. Hopefully I haven't overly bamboozled the board with bureau speak, but I'll be very happy to pause there and to take any questions in relation to anything I've said, or indeed in relation to the paper that's in front of you. Thank you, Sue.
Thank you, John. And I have to say that to start to hear comments like looking at those broader determinants and joining things up has to be, well, we know it's the right way to go, but to have more say and sway over what we do within our footprint, to me, augurs well for a better quality of service all round, not just you know, all of those partners. We're going to be far better sighted on not just what we provide, but what we want to provide as well. Comments and questions from anyone? Jason.
Thank you, Chair. John, thank you very much for the update. Just a couple of bits for me from the emergency planning element of the integrated care system, which obviously for me is a real positive. Only this week the Civil Contingencies Act has been reviewed. Going to probably likely bring new duties on health providers particularly. I know we've got the local resilience review taking place nationally as well, so accepting they've not reported fully yet, again that will no doubt have an impact on the integrated care thinking that you're doing at the minute, and obviously the role with the partnership as well. So I very much welcome the developments, but I think as always there's a real challenge ahead, isn't there, in the moving parts that's coming from other directions within government as well.
Yeah, that's a great point, Jason, thanks. And clearly the Integrated Care Board will inherit the CCG's current EPPR responsibilities, and you know, they continue to evolve and develop as well. And I must say, you know, we already have a lot in the tank when it comes to integrated care. We know we're really ambitious about where we want to go with Lincolnshire, but I think we shouldn't lose sight of the fact we're building on some really solid foundations already. And the work we do through the LRF forum and the way we've all worked together in that sort of emergency response, resilience way throughout the pandemic, I think has just consolidated and developed what was already a pretty strong working relationship prior to that. And Jason, thanks for your continued leadership in that. It really is valued and appreciated. Thank you.
Thank you. Councillor Bradwell.
Thank you. Well, I'm going to ask a very difficult question, John, because we can call things a Health and Wellbeing Board, we can call it Integrated Care System, and we can badge anything anyway, but what difference is this going to make? How is it going to make the hospital better? How is it going to make, you know, you've talked about dental services, and I hope that when they come under your banner that you will be able to make dental services much better. I mean, our dental service was quite good. Known the family for years. They've been in the community for about 60 years, the family. We've just got a new dentist come from Scunthorpe. She's privatising it. Most NHS patients have been told, oh, you've missed your appointments over COVID. You can't come anymore unless you're a private patient. So I just want to know, you know, we've now got an integrated care system, which is another change of name. I know you're going to work differently, but it's another change of name. And for me, as someone who represents the community, you know, I want to know what's going to change, really. How are we going to make things better? Because I have sat around the table with you for quite a long while, and we still have, and we're bound to have challenges, but some things haven't really improved. And for me, it is about how do we make things better? You know, and I know I've chewed today about pharmacists, but again, you know, it's only small things, but, you know, why shouldn't rural areas have the same as our towns or bigger communities? You know, I don't expect it everywhere, but I do expect in a radius of 10 miles, probably a pharmacy that opens on a Sunday. So what I want to see is us to really improve on what we've got, and I hope we can do that in changing the way that you're going to work. But, you know, I have to say that I've been here quite a while, so I want to be convinced, and I will sit and be very patient and wait over the next year to 18 months to see the flowers shoot up.
Thanks, Tricia. I think that's absolutely spot on, really. I mean, the fundamental question of you know, any of this and a lot of reorganisation we go through is what difference will it actually make to the people we serve? Be that sort of, you know, the direct provision of care like you've just described, or some broader benefits. And I think those sorts of the questions will be the litmus test throughout the next few years. We know that we're moving forward, yes, with ambition, and there's some good stuff happening, some brilliant stuff happening, and you know, things like ULHT getting out of special measures is a really good tick in the box. lot of work still to do, but I mean, it's great to shake that off. And there's a lot of really outstanding work that we've all done together throughout the pandemic. But we're not going to magic away some of the fundamental challenges that we have in Lincolnshire across the wider system just by changing the bureaucracy, are we? We know we've got really difficult workforce challenges, recruitment, retention. Prior to the pandemic, we know that across NHS England, we had a shortfall of about 100,000 staff in the NHS, and we know how that plays across Lincolnshire, particularly in the east. We know that we've got real quality concerns in some of our services, and we know that some of our services simply aren't as we would wish them to be. So I think we've got to be, like you say, fundamentally realistic. And I know you'll keep us well grounded in relation to all of that. I think the point that I particularly see is kind of threefold, really. The first is whilst patients do obviously have episodic relationships with the NHS, something goes wrong, they need to go to the NHS and get it fixed. They get it fixed. That's that. Most of the population we serve have an ongoing relationship with the NHS about the management of their care, their diseases, or a number of conditions that they have. And what I see is that the way we've designed the NHS nationally over the past number of years it's been very fragmented. And the point of moving to an integrated care system is that we have joined up care across all of the different aspects of care provision, built around the needs of the patient and their family. I know that healthcare workers across Lincolnshire, that's what they try to do, but when you talk to GPs about their frustrations with hospital services, you talk to hospital services about their frustrations with social care, you talk to social care about their frustration with GP services, all of that, we're all doing our level best individually, but we know that if we just joined up care in a different way, we could make things so much easier for the people we serve. So that's sort of one thing. I think the second thing is we know in our county we suffer, some of our populations suffer huge inequalities. I was looking just recently at the statistics around the top 20 most deprived towns in England and Wales. We've got number 1 and number 4 according to that. This is significant. And actually our most deprived ward in the county isn't in either of those two towns either. So we know that we've got to fundamentally try to kind of move the dial on health inequalities, social determinants of health, and housing and education and community support and loneliness and isolation and all of that. The NHS can do a bit on that, but fundamentally local government colleagues and other partners across the third care sector and others are better placed than we to do that, and we need to do all of that together. And then I think the third point is that by taking an integrated approach, I hope that we're all together going to be able to advocate for Lincolnshire in an even more stronger way than we do at the moment. So the sort of levelling up agenda, making Lincolnshire an even more investable proposition for government and for private sector, and to sort of really have an ambition about making Lincolnshire, a great economy, a great place to live, a great place to learn, a great place to receive healthcare, and all of that. So I get exactly the challenge about how we make it better for patients and their families day in, day out, and acknowledge fully the deficits there. But we can only work our way through that together. I think we've got to really sort of address head on in a way we haven't collectively really to date how we tackle health inequalities and this social and economic value bit, and then finally this advocacy bit. So I look to the future with ambition and positivity, but in no doubt that there are some grinding service delivery issues that you know, are happening day in, day out at the moment. And I think you're absolutely right to keep our feet to the fire on those, Trish.
Thank you, John. Sarah.
Yeah, sure, thank you. Just really to share with everybody that we've just been awarded some work from CQC for our Health Watch for Lincolnshire that will help to be part of national policy for CQC assessments of ICS. So hoping that Health and Wellbeing Board and everybody will be behind this, which is really very much about putting people at the heart of decision making. So listening to what they're saying, learning about their journey from primary care through to maybe living with conditions in and around their home environment and what that experience has been. Lincolnshire particularly was chosen because of the rurality against some of the towns and the city of Lincoln. So this obviously work, and we had a meeting with them today to say, can we use this work and share it and learn from it in Lincolnshire as well as it national, which they've agreed and said, yes, definitely. So we really, and I know, John, you and I are speaking about this on Friday, so we're quite excited to really learn how people are going to be put at the heart of all of this.
Thank you, Sarah. Emma.
Thank you, Chair. Thanks, John. Really interesting to read the paper and to hear from you. I think I would just make a plea, really, that we really take this opportunity to harness the contribution that the community and voluntary sector can bring to this piece of work. I think in your when you were talking to us all, you mentioned it quite a few times, but necessarily when you read the paper, it doesn't come across that actually this sector is going to be part and parcel of the decisions, and really understanding how we can maximise the use of the sector, who are already working very, very hard, but probably quite disparate, but they absolutely, as Sarah said, you know, kind of have their ear to the ground in terms of understanding exactly where the challenges are in those local communities and how we can better help those community and voluntary sector organisations contribute to the vision of the integrated care system. And I firmly believe that they've got a really strong role to play, and I would like that conversation to be happening at the outset of this rather than it coming to you know, those organisations kind of when the decision's been made, if that makes sense. So I just think it's a plea to make sure that everybody has that opportunity to contribute to the discussion at the earlier stages.
Thank you, Emma. Some great points there. The sort of leadership group that's designing our integrated care system, which we call the Better Lives Lincolnshire leadership team, involves quite a number of leaders from across the different sectors in Lincolnshire. Debbie Barnes and I sort of co-chair that, but the chair and vice chair of the sort of third sector network organisation, Lincolnshire Vet, Chris and Michelle, are part of that. As is Melanie Weatherly from Lincoln, and as our district councils as well as county council and NHS colleagues as well. So we are taking that integrated approach right from the off. There are of course some significant other partners who we want to continue to work really closely with. Not least our Lincolnshire Police. Clearly, that's a day-in, day-out relationship, and colleagues such as the university are going to be, I think, really important for us as well. And all of those, I think, relationships are in good health at the moment, but we know we can make more of them in terms of an integrated approach. And the other point I wanted to say is I think that the NHS is pretty poor at really being able to engage with and listen to the communities that we serve. And I think there are significant skills and experience amongst our partners, be that district council partners, county council partners, Health Watch partners and others. And I believe that our third sector network of these wonderful organisations, different shapes and sizes across the whole of Lincolnshire, again have a really important role in advocating for the communities and the sorts of people that they serve as well. So it says very much, we're all in this together, and from the NHS perspective, we fundamentally understand that we need to be guided and advised by our partners and the public in terms of what's really matters to them, and not do that through rather sort of binary NHS lens that we have for quite some time now. So thank you.
Thank you, Emma. Yes.
Thank you, Chairman. I'm going to sound like a cracked record here, probably not as articulate as some of the people that would normally sit here, but as has been said before, and Mr. Turner, you were talking about engagement with the grassroots, as indeed of others clearly, and I'm waving the flag here. District councils, as you've mentioned yourself, play a vital role in this, which I know has been said before, and the national criteria pretty much says the same. So with that in mind, we would be very interested and welcomed, firstly, reassurance that we will be engaged with, that we will play an active role, and in terms of the emerging ICB and its 6 committees, how will they be developed? What will the district's council's roles be in that? And in terms of, excuse me, I'll just check my notes here, on page 176, 2.1 of the report, it refers to the ICP Planning and Development Workshop, and we would be very grateful if we could have a date for this workshop and who's been invited to it. Thank you.
Just thank you. I'll pick that one up as well, Sue, if you like.
Yes, please do.
Just to say that certainly from the NHS point of view, and I sense all of us together, yeah, absolutely, district councils are a fundamental part of the fabric of service provision in the communities across Lincolnshire, and we fundamentally recognise that. And I've personally been working with the chief executives of the district councils for quite a few years now, and I speak regularly with them, sort of individually and collectively. 2 of them, it happens to be Angela Andrews and Ian.
Just the point I was going to make was, and your chief executive at North Steve and Ian Fitch.
And Ian Fitch are 2 working as part of that leadership team on behalf of them all collectively. So it's right in there, you know, with the design and development of all of this. I must say, I think that the key role that district councils will play is more in the partnership side and the ICP, and we'll come on to that in a few moments, Sue, rather than the Integrated Care Board. I think the Integrated Care Board will be primarily concerned with integrating and delivery matters within the NHS itself. I think it's the Integrated Care Partnership, which obviously the Integrated Care Board will work with, where we really work together in terms of the broader health and well-being plan and approach and actions for all of us across the county. So my sense is that that's probably where the contribution and input of districts will really hit the mark.
Just before I bring you in, Councillor Bokic, I think what I would like to say is to really reinforce the point that I think I make at every one of these meetings, which is along the lines of we have a marvellous opportunity, as Emma has pointed out, a really great opportunity here to be able to say, this is what Lincolnshire wants and needs. And so rather than slavishly follow guidance or dictates from wherever, if it doesn't suit Lincolnshire, then we all of us, and I mean all of us, as parts of the system, need to be able to say so. And as long as we are able to offer a sensible alternative that works for Lincolnshire, then we should be allowed to do so. But it does mean that we must at every opportunity, if it's not working for us, then we find a way of working that does. Councillor Bokic.
Thank you. Well, I just think the point is that we all have to start working together, which we haven't been doing, and we're still not doing. I mean, the last 2 weeks, particularly between the NHS and County Council, you know, we've had some tense meetings and we haven't been all as helpful as we should be. District councils, we need to sort our housing out you know, we've got a main, especially on not just on the East Coast, everywhere around Lincolnshire, we have to sort our housing out, because until we do that, then we're not going to get anywhere. We know we are all working together. We've got a good team out there with everybody, not just county councils, district councils, police, health, but there is a hell of a lot more to do. And we do need to get ourselves sat down there and get everybody working together so that we can sort some of these issues out.
Thank you, Wendy. Okay, are there any other comments or questions at all? In that case, I think this paper is just for noting.
Absolutely.
And if everybody's comfortable with that, we will now move on to item 7B, which I believe you, Michelle, are going to speak to. So thank you.
Thank you, Chair. So, as John has alluded to several times in his presentation, the ICP, which is the Integrated Care Partnership, will play a vital role in the new arrangements, and we'll give you a brief overview of where we are with regard to those plans. So, as John said, we moved, the timeline has moved from April to July, and very specifically mentions the date of the ICB needs to be formed, of the first. However, with regard to the partnership, the details around that within the revised guidance were less clear, and so we are working very closely with our colleagues to align our new arrangements with the revised timeline for the ICB. So what we've done is set out the plan previously and updated the report so colleagues and the Health and Wellbeing Board are very much aware of where we are with regard to that. As we've said, what we want to try and do is ensure that everyone within the wider system understands the part they can play within the partnership and the requirements of the partnership. So it's required to have, every system is required to have a partnership, and it's expected to have a minimum membership, and that's required in law, and it's tasked with producing an integrated care strategy for their area. So the expectation is that the ICP will play that critical role to engage in wider partners and facilitate that joint action to improve health and outcomes, influencing the wider determinants. So what we want to try and do is set out within the arrangements that we put in place how we're going to achieve some of those key points and the expectations within the partnership, including helping people, taking that holistic view, addressing those health inequalities and improving the wider social determinants that we've talked about, and then contributing to those wider improving life chances for all our population. So I've touched on the timings, and we're going to co-align our arrangements as much as possible within the new timeline. However, accepting that, as John said previously, the Health and Wellbeing Board is a statutory committee of the council, and the partnership needs to be a statutory committee of the council and the ICB, and so there are formal processes that we will also need to go through as a county council to enter into those arrangements in a legal and proper way to do so, and we're working on those, and once those are in place, obviously we'll report back to the board in due course. What we want to do is engaging the board. I know that prior to my engagement in this last year, it was Lincolnshire's ambition for the Health and Wellbeing Board to take on the whole responsibilities of the ICP. However, within the guidance, there are some limitations around that we, as you say, Chair, that we need to work through to make sure the system we put in place and the partnership's right for our area and embraces all of the partners that we want round the table. So we're trying to challenge that and make that work for us. And what we want to do in order to do that is we've set up as you say, a workshop on the 26th of April, inviting colleagues from the Health and Wellbeing Board, some district chief executives and colleagues from the ICB, including Sandra Cash as well, to have that conversation about how our previous ambition of evolving the Health and Wellbeing Board to encompass all of those responsibilities, how does that then work with regard to having that ICP, and how can we then ensure we fit within the guidance and hopefully what will become law very shortly, but how can we make that right for the work we do, avoid duplication, minimise and reduce any gaps that we identify, and also then ensure that everyone has a voice around that table that can contribute to the further development of that. So we're hoping that that will be really important. So I would encourage that people that have received an appointment for that find time in the diary to come along to that and prioritise that. Appreciate it is difficult to find time and people are very busy, but we do really feel that that's a really good opportunity to explore what our previous ambition was and how we make that work in the new arrangements that have been set out before us. So we've explained the difference between the Health and Wellbeing Board and the Integrated Care Partnership. We have got guidance on what that partnership needs to constitute as, and we want to make sure that that's right for the area that we are. And what we want to also do is make sure when we're having those conversations, we understand that the responsibilities of the Health and Wellbeing Board continue to be achieved and that the ICP complements those, wraps around that in a cohesive and seamless way to ensure that we can deliver on the ambitions that we want going forward. I'm hoping that explains where we are. There are still lots of unanswered questions, but we're hoping partners will come round the table to help us shape that going forward. Thanks.
Thanks very much, Michelle. Any questions for Michelle at all? Michelle knows my thoughts on this, and it goes back to the comment I made a few moments ago around, let's, you know, I hear the guidance, but it is very much a case of, you know, that prescription around, you can't do this without doing that, which is fine as long as it works first and foremost for us here, and pushing back if necessary, if it doesn't work, that we do say so, as long as we've got good reason behind it. But if I've read it right, the guidance, the ICB's got to be formed first before the ICP can be formed, and with luck, as you've said, the B becomes law on the 1st of July, so it's any time or after then. Is that?
That's correct, and what we'll need to do is work through the processes that we need to go through as a county council to align us closely to that, and I think we're just about there now with regard to what we need to do. Unfortunately, we can't state that until the formal bill's announced, because obviously we're all subject to the outcome and the date of that, but I'm happy for John to add to that.
I think you've said it all, Michelle. We've been planning this and developing this together for some time. I think we're quite lucky in Lincolnshire in that we're one of only 3 geographies in the whole of England where we have one Health and Wellbeing Board and one ICP. Most others, well, they have more than one, don't they? Some have 5, 6, 7, 8. So I think the question for us is, how do we make a virtue of this and make sure we have a differential role between the ICP and the Health and Wellbeing Board that works well in terms of the legislation, but also that was sensible in terms of no duplication, and we take it forward together in a way that works for us. So.
Okay. Thanks for that. So again, I believe this paper is for noting, and as long as everybody's comfortable with that, I will move on. Well, before I move on, Derek has suggested that item 7D, that it's not time limited, so that we can take this, that we're running a little bit behind time, so we'll take 7D at another point. So Sarah, if we now can move on to your transformation programme. Thank you.
Thank you, Chair. Afternoon, everybody. I'm Sarah Connery. I'm the Chief Executive of Lincolnshire Partnership, NHS Foundation Trust, and I'm delighted, hopefully, to be joined by my colleague Nick Harwood, who is our Associate Director for Adult Community Services at the Trust. So, first of all, thank you very much for allowing us the time to talk about this really important work, community mental health transformation. And I think it's a really good segue for much integrated care system working in practice. So, as I formally reported, Lincolnshire was one of 12 sites selected for early implementation of community transformation, and funding has been received in tranches. So we were formally approved in 2019, and we began implementation in earnest in 2020 in a phased rollout. Just to sort of frame the conversation, that this has been a very challenging piece of work as we try and connect bits of the system to each other. It can be time consuming, it can be complicated, it can be complex, but it's the right thing to do for our population. I am conscious of time, so I will be handing over to Nick now, who's going to share some slides on the programme. Thank you.
Thank you, Sarah. Oh, I'm echoing. That seems to have stopped. Yeah, thank you for that. And just as Sarah just said, just some of the further kind of backstory, really. Yes, we were one of 12 sites selected nationally to be an early implant. Big ambitions to genuinely transform the way that we deliver mental health care in the community. I think it's probably worth noting the starting point, really, which is perhaps a service that has never been in the headlines in many ways, although has been the core to our community offering for many, many years. We've seen lots of specialist services come and go, really, but they've always remained core. And I don't think it's unfair to say perhaps haven't had the investment they deserve for perhaps we're talking decades. So this is a real opportunity to do something completely new, completely fresh, and kind of rip up the rule book and start again, really. As Sarah said, was able to make a case for funding, and like I say, it was really good to be an early implementer. So we've helped shape the national picture really around what this rollout will look like. So we're a year ahead of other systems. That's not to say that it's not had its challenges, but you know, we're very pleased to be on this journey essentially. An overview of the programme. So essentially, there's some really key principles that we're trying to achieve with this. And interestingly, a number of those points have been raised in today's session already. But fundamentally, putting services close to where people are. So using those footprints that are our primary care network areas and putting in deliberately, if you like, a new service, which we're calling integrated place-based teams. Hopefully, you know, it does what it says on the tin. It's integrated in terms of primary care, our third sector, our mental health provider, and all the other parts of the system that where mental health is going to touch. The reason for sticking a team or creating a team closer to primary care, which is where they are, they're in neighbourhoods, they're in places, was to kind of fundamentally understand where our gaps are. We know that our services, particularly in community mental health, have inadvertently created strict criteria. It's what happens when services are stretched for resource. We make criteria strict. The front door is difficult to find. You know, people will report a really good experience when they get in, but it's difficult to get in. So we need to change that. We need to make that. We need to make our services more accessible and that there is a place for everybody. Population health led, using the data that we've got to ensure that we provide, you know, we've got the services in the right places. And not to put too fine a point on it, this is a large cultural shift. And I guess the ICS, in terms of that legislation and other elements, are a big cultural change for the way in which we deliver services in that more joined up way. So it's important we focus on the culture and we put programs in place for people to be able to, you know, talk, express opinion. Its intention is to be multi-agency, cross-sector collaboration, to understand that impact and have that impact at local level. Again, I'm pleased that it's come up because it segues in nicely. We are putting in significant investment into our community assets. We acknowledge that as a mental health provider, we can't do everything. We've tried to do everything, and it's led to our services becoming saturated. Hence, it's difficult to get in. It's difficult to transition people back out of mental health services into their communities. So, as I say, considerable investment in our community assets and that third sector. Fundamental to the programme, and it's through its philosophy really, is that co-production and collaboration. Who are we to say what people want? Who are we to say what people need in their local communities? We need to hear their voices, and more than that, we want people with lived experience involved at all levels of our programme. I don't want to hear the voices. I want people sat alongside us developing services together. We know we've got a big piece of work to do in upskilling and training and coaching local people and clinicians to improve the quality of care for people living with serious mental illness. There are gaps, and we want to be able to fill them. And if we want colleagues and partners to work together to improve quality. We've got to provide the training and the skills to be able to do that. Volunteering, peer support, running through the programme. So a number of new roles that draw upon the experience of people who've lived with mental health problems or have accessed our services. We want to ensure we're offering that digital offer. You know, if we've learned nothing from COVID, it's our ability to work in different ways. And digital plays a part, and it plays a part in two ways. One, to improve access and accessibility to information, but we cannot lose sight of people with digital poverty and how we reach out and ensure that they've got an equitable offer. People with serious mental illness die much younger than the general population. So we have to embed a programme of physical healthcare checks, and it needs to go further than a check. A check does nothing, it identifies a problem. It's the so what's on the other end, ensure we've got robust and supportive systems around healthy living, exercise and diet, smoking cessation, alcohol misuse, drug misuse, etc., and joining all that together. Part of the programme, I've just talked about the integrated place-based teams, which I'll talk a little bit more about in a moment, but there's also some dedicated services. So there's some areas of need that a number of systems haven't got in place. They're facets of their community mental health team. So some dedicated areas. Eating disorders is one. We've seen a huge rise in cases of eating disorders during the pandemic. So we're putting in new services with a specific focus on highly trained evidence-based approaches to eating disorders and that connection to primary care and the communities. Community rehabilitation, those people with long-term, long-standing mental health difficulties who have problems maintaining their own independence, if you like, their accommodation, their activities of living. So a team wrapped around the person to be able to support their rehabilitation back into communities. You know, not caring for people in hospitals all the time when there's a better option out close to where they live. And our, what we call our personality and complex trauma service. So those people affected by what would be termed complexities in relation to personality, and a dedicated service, again, following the evidence base and the kind of nice guidelines around how we provide services. And again, that link to primary care and our community sector. And ultimately what we want to do is free up our specialist staff within our community mental health teams to be able to care for the people with the highest need, the greatest complexity. As I said, we are trying to absorb and do everything for everybody, and we need to share that. We need to share that across with our partners, so our staff can really focus on them specific interventions and you know, complex pieces of work with people. I won't dwell too much on this, but it's just a visual representation of our intentions around the fluidity of the model. So people can be accessing any of these at any one time, and they're not stuck to an area. But we call it our 3 plates, and we see this as fundamental. We don't feel we achieve anything unless we get this right. And that is people being cared for in primary care with support, with mental health professionals in primary care. That's your middle. That's the middle kind of sector there, that integrated place-based team that I've talked about. On the left-hand side, the community, voluntary community and social enterprise sector. As I've just said, investing in that so that people can be cared for in communities and have meaningful activity and occupation within their own communities. And we've introduced roles such as social prescribing link workers with a specific focus on this programme. Community connectors, a new role that we've brought in to enable all those smaller grassroots organisations with a small voice and difficulty receiving funding at times to come together. So we're putting together locality partnership groups, bringing everyone together who works in the mental health field, and how can we make that stronger? How can we all work together to do that alongside the investment that we're putting in? And then on the right hand side, as I spoke about this, sorry about the acronyms and things, but these are our dedicated and specialist services. So we just need that whole pathway working together, and that's where we get to a place for everybody, that there are no gaps in service, that everybody has somewhere that they belong. I don't believe that anybody puts their hands up and says I've got a mental health problem for no reason, and therefore we shouldn't be rejecting or denying anybody some level of access to our services. The trauma-informed component, trauma-informed care is an approach to making sure services are set up in such compassionate ways that we don't re-traumatise the traumatised by our processes and our rejections. So yeah, very MDT approach, all of us working together from primary care into secondary care into the third sector. Next bit really is just some sort of roadmap stuff. Where are we at now? So we've talked about a big ambition. It's been rolled out in phases. We are working on our integrated place-based teams. I think this is a little bit out of date because we've now got more than 4. We're up to 9. And next year we'll see us get up to that full 15 primary care network areas covered. We want to recruit more psychologists. We want to ensure that our workforce are more psychologically minded and we're delivering the interventions that have the best evidence base. Just working through, we've got local blueprints for local patches to interpret in the way that they wish. We've been set a set of standards by NHS England, but unlike a number of programmes, not completely defined. That is the whole point of population health, isn't it? You tailor your services to the local population. I've spoke about people with lived experience being fully embedded in the programme of work that we're delivering, those dedicated work streams. Also, not mentioned at this point, but also very important, we're linked in with our, our social care colleagues and the local authority to ensure everybody's having the conversations in the right places. We want to co-locate our teams in community hubs and community centres, so it's not always coming to health facilities for their care. We're accessible and in people's communities. We've set up the Lincolnshire Mental Health Helpline and the Mental Health Advisors Helpline to support people with mental health problems who need to be able to speak, and for our professionals and colleagues to get advice on mental health. Community rehab team I've talked about, we've launched a website called It's All About People. If you Google that, you should find the website and there's more information there. Some elements of the digital expansion. Really proud that was able to roll out our nightlight cafes, which started in Lincoln, but we've now got more cafes in more towns in Lincolnshire and more to come. We want that county-wide coverage for that. I've spoke about a number of these things already, but there's a new role in primary care using the additional roles reimbursement scheme, which is a specific mental health worker embedded in primary care, working as part of the primary care MDT. So seeing people, screening, signposting to the right place, trying to get people into the right care at the right time, helping with the education and upskilling of knowledge about mental health with our primary care colleagues. I've mentioned the community asset development work, so that investment in the third sector, and I've mentioned the roles that we're wanting to add into each patch to ensure that it's not all those clinical roles that are difficult to recruit to. We've got such tremendous skills out there in the third sector. I've been blown away by the dedication, the motivation, and we need to, work together as partners on that. I've spoke about the cultural change kind of processes and things like that. What's to come? So some of the challenges, I guess, and some of the areas that we need to work on. We need to get the collection of data correct. I know we do have to feed beasts, but it also helps us model our population health going forward. And we all use different systems, so it's quite difficult to pull that together. So I guess that's something we'll be talking about more as the ICS develops. How do we share and join up our data collection? Achieving those targets around physical healthcare checks. Rolling out those 15 place-based teams. We're underway now. We've got the agreement for the next year's expansion of the transformation, which is great news and demonstrates the systems approach to wanting to invest in mental health more than we've seen before. Everybody having a personalised care plan, so care is tailored to the individual, not to a system or a process. And ensuring we've got some dedicated communications and engagement time, so we can go out there and do more work around communicating this vision to our partners. What will be nightlife cafes and community connections all over the county, fluid pathways for people in mental health services that don't have drop-offs, cliff edges, difficulty accessing the front door, integrated digital offer, continuous and active dialogue. We're all of us in the programme are so passionate that we just keep talking about mental health. We've got to break down that stigma, that ongoing upskilling and training of communities. Reduction in prescribing. We prescribe a lot of psychiatric medication in Lincolnshire, and we need to look at actually the evidence base would suggest more psychological therapies are needed. Ensuring people have got a what matters to me plan, that personalised plan. And there are some targets. There are some targets coming from the centre, which is to ensure that people are accessing services within 4 weeks. And that's where we want to move to. So in a couple of years' time, we'll have 15 integrated place-based teams, fully integrated with their community mental health teams, a primary care, third sector, invested hopefully over £1 million in the third sector, with significant places for people to go that are alternatives to mental health services in a traditional way. 200 new roles are coming as part of this programme, and we are wanting to increase our access to over 6,000 people. So that was essentially a whistle-stop tour of the programme, where we're at, our ambitions, and thank you for the opportunity to speak about them.
Thank you, Nick. Much appreciated. Right, he's gone. Councillor Bowkett.
Thank you. Well, Sarah will know this is one of my passions, mental health, and I am really, really pleased that they are going to be brought into GP practices, although I'm a little bit sceptical how many will take it up, because I think we all know that if you go to a GP practice, mental health is not on their terms. They don't want to talk about mental health, don't understand it. So if we can get that into GPs, I think that's really, really good. 15 integrated place-based teams by 2024. 2 years is a long time, but you know, maybe we can bring it forward a year, and that would be really good. Personalised care plans. It's been what people have wanted for many, many years. You know, not be discharged out of hospital and then just left to the system. So I just think it is really good, and I'm looking forward to working with you to getting this brought out, because it's just fantastic news. So let's hope we can do it, and I shall be Googling It's All About People just to see what we're doing. But thank you.
Thank you, Wendy. Councillor Kendrick.
Thanks, Chairman. Yes, I'd echo Councillor Bokett's remarks to some extent. I agree with there's a lot of interesting and positive stuff in this. The one question I'd ask, and I noticed you've got on the roadmap expansion of crisis cafes, which leads to my question: where do crisis teams fit into this overall plan? Because I know sometimes that there are issues with people accessing crisis teams.
Yeah, thank you for the question. So there is a protocol in place. I'll ask Nick if he wants to come in and just add a bit more detail on that from a clinical perspective, if he's still there.
Yeah, no, absolutely. Yeah, I mean, fundamentally, this programme is targeted to severe mental illness, not community mental health, but that means that we have to join up all our services, don't we? And I think it's fair to say, Rob, would all acknowledge that there's been some challenges around crisis teams and crisis care. Our demand outstrips our capacity, and things like crisis cafes, nightlight cafes, and other wellbeing hubs, and other things like the mental health helpline are all to take some pressure off, essentially, but also ensure there are genuine alternatives to just being under a crisis team. So yeah, they are not specifically in scope of the programme in terms of the investment, but very much in the scope of our planning in terms of our seamless pathways going forward. So yeah, there's work to do, but absolute dedication to do so.
Thank you. Emma.
Thank you, Chair. Thanks for the presentation, Sarah and team. That was really interesting. Just wanted to flag that we are in the process currently of working on the Let's Move Lincolnshire physical activity strategy for the county. And it struck me through the presentation that we heard there that there's a huge amount of alignment that I think we really have to make at that strategic level to ensure that we're not treating mental health and physical activity in silos. We've had some really strong examples, not only through Active Lincolnshire, but many organisations through the Mental Health Transformation Fund of delivering activity-based sessions that have helped people significantly with mental health, but they tend to be quite short-term. You know, it's almost like we can pilot these opportunities, and actually what we really need to do is find a way to deliver those at scale on a sustainable basis, ongoing. There have been some wonderful examples of dancing on the beach and yoga in gardens and dog walking groups and all sorts of other really amazing things that have genuinely helped people but we often find the funding comes to an end, then the activities come to an end. And to me, these two topics have absolutely got to be intrinsically linked. So I'd really welcome the opportunity to have that conversation. I think your colleague Sarah coming to some of our workshops around Let's Move, and also the same in terms of digital content as well. So the All About People website, hopefully we can find some ways to link that in with the Let's Move Lincolnshire Club and Activity Finder platform that's been funded through LCC.
Before you come back on that, Sarah, can I assume then that you are going to organise us all for Skegness Beach for the next meeting then? Sarah.
Yeah, thank you. Absolutely agree, Emma. And, you know, we've connected up, haven't we, in terms of going forward. It's that sustainability, I think. You know, we've all got great ideas, but small amounts of funding can do great things, but we've got to make sure that it's there sustainably into the future. So now I'm absolutely delighted that I can get involved in building that strategy. So thank you.
Jason.
Thank you, Chair, and Sarah, Nick, thank you for your presentation. Unfortunately, on a daily basis, I see some of the real difficulties for our communities in this area of business, and unfortunately, I think it's going to get worse looking at the current challenges for individuals and communities as well. 3 points from me, really. The first one's around benefits of the 9 integrated teams already. Are we seeing some early benefits of the work that's been done around there? Because I think that's a good news story, for knowing some of the stuff I know already, but that needs to be shared wider. The dual diagnosis issue, mental health, drugs, alcohol. Again, are we going to get that right? Because that's one, unfortunately, where we see people going through the cycle. It doesn't resolve, it makes the situation worse. And the last one is just the workforce challenge. I do not underestimate the challenge of getting new staff, not just in terms of Lincolnshire, but the right skills, and accepting this experience comes with exposure. But have we got a real good plan to be able to attract the right people coming into the county to do these really important roles as well?
Yeah, I'll come back in on that, and I don't know whether Nick might want to comment as well, but absolutely in terms of the reddest risk on our risk register at the minute is workforce recruitment, not just recruiting but retaining as well, and COVID's definitely had an impact in terms of people evaluating if they had the choice to retire, then they're taking up that option to retire and not deciding to come back again, which is unfortunate. But yes, the Trust is doing lots of innovative work around international recruitment, about new roles as well. As Nick has said, we can't recruit more qualified staff, so we're looking at mental health practitioners in terms of not necessarily the traditional qualified roles. So there is a lot of work going on at the Trust. And in terms of the earlier point about can we go faster, we could if we could get the workforce. And I said the funding has come in tranches, so that has been a limiting factor. But now that we've got the final tranche of funding, actually it's going to be recruiting to those roles that will potentially hold us back. So we've got to really get our thinking caps on and come together as a system on that. In terms of the increase in demand, you're absolutely right, and I've reported previously to this board as well about what that increased demand looks like, and we continue to track it, and some of those service lines just keep going up. They don't seem to be plateauing, and hopefully, you know, police colleagues will see the benefit soon in terms of our mental health assessment centre, where we can get automatic police drop-offs, because we understand that it can have a massive impact on your capacity when you're conveying and supporting people who are in a mental health crisis. But the work around the Mental Health, Learning Disabilities and Autism Alliance that John spoke about previously, we have got the Chief Executive of the OPCC there in attendance, but I think there's a lot more that we can do at the operational level in terms of making sure that we're all using our resources effectively. I don't know whether Nick wanted to add anything else to that. Thank you.
Yeah, probably on the 2024 thing, which indeed, I mean, I guess we were saying 2024 is when we want to see the programme fully realised in all its elements. In terms of the 15 integrated place-based teams, we'll be recruiting to the final 4 from now. So depending on how recruitment goes, everywhere will be active and live in terms of having that offer. But yes, as Sarah said, staffing challenges. Just on the dual diagnosis comment, actually, which is a really good one. There's definitely more work to do. We've done a lot of work internally to look at that strategy, and we're doing an awful lot of joined up work with We Are With You now. I think some of the difficulty can be that you end up in chicken and egg conversations. Do we treat the alcohol and drug misuse first before the mental health? In reality, we have to treat everything together, and that goes back to that personalised approach to care. We have to just get everyone around the table that can meet that person's needs to have that discussion. Pleasingly, in terms of the transformation programme, we've got police representation. So Chris Davidson is quite actively involved with us, and quite a number of the neighbourhood police attend the partnership groups. So more to do, but really appreciate the alignment around that agency, the multi-agency work, in particular with the police.
Councillor Gray.
Thanks very much, Madam Chair. Thanks for the very enthusiastic and really upbeat presentation. And I like the infographics. They're good, they're clear, so that's really good. You mentioned there are 9 integrated place-based teams in place, but I don't think you said where they are. And also, as I represent parts of East Lindsey, is there a community hub in East Lindsey? Is there a nightlife cafe in East Lindsey? I would just be interested to know, are those things actually in East Lindsey now? We do cover 700 square miles.
I'll let Nick come in terms of the detail there. Thank you.
Yeah, no problem. Our first 4 sites, so our early implementer sites, were Gainsborough, Grantham, Lincoln City, and Boston. And our next sites were, I'm saying towns rather than PCNs, but it covers those patches: Louth, so East Lindsey, Skegness, First Coastal. 4, 5, 6, 7. Lincoln, the north of Lincoln, and Stamford. So the sites left are the 2 PCNs around the south of Lincolnshire, around the Spalding area, Sleaford, and the south of Lincoln. So that's where the current coverage is. In terms of East Lindsey, one of the challenges we've had with the nightlight cafes is finding organisations to host. They're led out by the Axe Trust, and we approached them because they'd set up the Lincoln one. So they're supporting third sector organisations to deliver this, and we weren't able to get anybody interested from that part of the county. So I'll be very interested in future, relatively soon, conversations about how we can manage that and where they could be hosted. We do have wellbeing hubs. I'm going to struggle to tell you the location of those, but they are in East Lindsey and certainly in the east. So yeah, bit of work to do regards that final rollout of the nightlight cafes into that patch.
Thank you, Nick. John.
Thank you, Sue. I really enjoyed the presentation. There's clearly a lot of really good work happening here. Clearly a lot more to do as well, but it really was a very encouraging presentation. I think Sarah, something I'd like to just explore with you actually is what are the learning. This seems to me integrated care in action. Working with mental health, working with general practice, working with the police, working with the third sector. This is a great example of we're already doing it in lots of ways. So I'd value your thoughts on another occasion about sort of what are the learning points from this that we can take into other areas where perhaps we're not quite as advanced in integrating care and services in the way we need to be. But congratulations for the work you've done so far. It's really impressive.
Kevin.
Thank you, Chair. I just wanted to offer a couple of comments as a kind of gloss on the presentation, if I may, and speak a bit about the ambitions of the Trust generally, and reference, I think, the points about kind of impatience with making this happen more quickly. Sarah will confirm that I am possibly the least patient person in this room, and I encourage her a lot to do things at pace, but this programme is indicative of, I think, of the ambition that we want to realise as a trust. And there are 2 aspects to that, from my perspective. The first is that we need to get, and it's to your point, John, about this being the ICS in action, I think we want to be much better at building partnerships and alliances and judging where others are better at doing things that we might historically always have done. That's partly about getting the right capability to deliver services to our patients and service users and the public. And that capability might sit outside the trust, it might sit in the voluntary sector, it might sit in the private sector, it could sit anywhere. So it's recognising that and building those partnerships better rather than just being a provider. That creates more integrated care. It also sweats the taxpayer's pound potentially rather better, which, with my taxpayers' hat on in search of value for money, that's a good thing. And the second ambition that I'm really keen on is that we don't turn people away. I get really fed up when I hear about people being denied access to a service because they don't meet the criteria. Now, there will always be people that we can't help and that isn't part of our that can't be helped by part of our service portfolio. But it seems to me our job in those circumstances is to support people to the right place. So, we might be the wrong door, but in a sense there is no wrong door because we'll pick people up and take them somewhere where they can. And we're not as good at that as we should be. So 2 ambitions, being much better at building partnerships, being much better at recognising the skills, capability and contribution of others and encouraging, supporting and building that capability and not turning people away. If we can't help them directly, then we'll find someone who can. Thank you, Chair.
Thank you, Kevin. Are there any more comments or questions from anyone? In that case, can I thank Nick, Sarah and Kevin for the presentation and their own comments. And we note the paper. We'll now move on. As I've already mentioned, we will skip item 7D. We will now move on to item 8A. I know we've got, well, I hope we've got Gareth online, but I understand, Gareth, this simply is almost nothing further to add at the moment. So I will just let you agree or disagree with me. Thank you.
Yeah, that's the case. So yeah, we haven't got any updates from national and regional around 2022-2023. However, we expect that will come probably in May. So in terms of the paper, it's just outlining our priorities for the next financial year, and the Better Care Fund's likely to be a 12-month period again for next year, with then a multi-year review to come.
Thank you for that. I don't believe anybody's going to have any questions at all when there's nothing more to add, but you're very welcome. Nope. Okay, thanks very much indeed. Again, we note your comments. Moving on to agenda item 8B. Again, I assume that you've read the paperwork. Are there any comments or questions that you have on this item? Nope. Okay, thank you. So finally, moving on to the forward plan. Can I suggest that if there's anything that you would like to have put on the forward plan, that you get in touch with Alison, and then we'll discuss where we're going to put it in and where it can be slotted. But please don't be afraid to bring anything forward. And on that note, I will now close the meeting. Thank you for your time.